going to discuss some wound care management in kids and just discuss a little bit how they're different from pediatrics to adults. There's not a lot of difference. There's a few major ones, and that's about it. I thought what I'd do is just take this morning, as you all know, since most of you were here, I talked about the 5 top pediatric wounds. And so I just thought I'd take those and we'll talk about the management of sort of these 5 top pediatric wounds that we saw in our outpatient clinic, or we see in our outpatient clinic in Colorado. So again, I broke up pressure ulcers because they're slightly different between neonates and older kids. And as we discussed this morning, and I don't know if you guys went to the pressure ulcer symposium during lunch, it's just a matter of education in the context that just educating people with regards to that they actually truly exist. And again, I'll just reiterate, it was when I started this profession in pediatric wounds, just the fact that so many people that were healthcare providers for children's, from doctors down to parents down to, the janitor, nobody really had a good concept that yes, children do get wounds and yes, children do have chronic wounds. And so it's just a matter of education and letting folks know that there exist. And just remember from this morning that the vast majority of neonates, when it comes to wounds, are all device related for the most part within the NICU and the PICU. And we really, at our institution, it took a long time. And this is so labor intensive. I can't even begin to tell you how labor intensive it is. But at the end of the day, it's so incredibly worthwhile for you to get a committee together of across the board folks to help out with pressure ulcer prevention, both in the NICU and the PICU. And so what we ended up doing is we ended up having a committee of about, if everyone met at the same time, there was about 20 of us on this committee, which if everyone meets at the same time, that's not a very good size of a committee. It's too large because everyone wants to talk and no one wants to listen. But because of schedules and so forth, at any given period of time around the table, we would have 8 to 12 folks. And I was the physician lead / the physician champion for our hospital as the pediatric dermatologist and as the wound doctor. And then we had NICU nurses and we had supervisors and we also had physical therapists, nutrition. We had a social work. We had a whole variety of people that were on our group. And let me just say, again, this is my second life. I was a bureaucrat and as a person in the military for 16 years before I went back into dermatology. And you have to, and I can't emphasize this enough, you have to get people from the top to be part of the system. Because you, as, I sort of consider myself sort of the middle ground. So if you are doing all this work and nobody at the top supports you, all of this work is not going to be supported, and you're just going to be doing a lot of work that's not going to be able to be implemented throughout your hospital. And we were fortunate. We had a vice president of risk who was very interested in the prevention of pressure ulcers, because in the United States, if you get a pressure ulcer in the hospital, the insurance company will not pay for it. And so it's at the cost of the hospital to treat that. And if you went to the pressure ulcer prevention during lunch, you see that, we're talking millions and millions and millions of dollars. So Medicare will no longer pay for hospital-acquired pressure ulcers. And so it's big bucks for people in the United States. And so as part of your committee, get someone from the top to be there and to support you, because then once you get your data, you'll be able to present it, and then the other people will listen, and you'll be able to make change in your institution. I'll say, don't forget the OR. we learned this lesson first at the VA, actually, where we had lots of sacral pressure ulcers from complex cardiac heart surgeries or from trauma patients. And we actually were doing this sacral dressing things years ago. I'm not saying that we were pioneers. I'm just saying that the Mölnlycke sacral pressure dressing has been around for a while. And we started instituting this in the VA, and we found a huge reduction, just like the folks in Melbourne found a huge reduction. And one of the things that really helped us at the VA that we actually took, and I did at the Children's Hospital, it's one of the benefits of being old and working at 4 different hospitals all at the same time, is we actually had our physical therapists go into the OR during surgery and look at placement of patients on the operating table. And I'll tell you, that alone made a huge, huge difference with just getting physical therapy's input on how patients were being positioned in the OR was huge. And so we translated that over to our Children's Hospital for the NICU patients and for the PICU patients who had to go in and out of the hospital or in and out of the OR. And that made a big difference, just repositioning patients every now and again or doing a different position. And it's very important that the physical therapist actually be there in the OR during the surgery to see how the patient is physically positioned. It can make a big difference with regards to pressure ulcer prevention. Oh, see, I'm so used to it. I'm a man of habit. So for the older children, again, you could sort of think of this as device-related. Wheelchairs were our big bugaboo, and the older kids, most of them were spina bifida or spinal cord injury patients, although we did have a few with severe scoliosis that were confined to a wheelchair, but the vast majority of the patients that we take care of in the outpatient wound clinic are spina bifida patients. And I'll just reiterate one of the things that I talked about this morning is the physiatrists, they do not make it as part, at least in the United States, in our institution, did not make it and still do not make it part of their routine physical exam to actually take the children out of the wheelchairs and undress them or just pull down their pants and just look at their sacrum or their heels. That's not part of their routine. And so if the parents don't mention it, then typically the physiatry folks don't address it. We were fortunate at the VA, at least, we had a combined wound program with both pediatric medicine and physiatry, so that actually worked out very well. The physiatrists, for whatever reason, were reluctant to become part of our pressure ulcer prevention group at the Children's Hospital. But we finally beat it into their heads that they need to start looking at these children's butts when they come in for their sort of routine. Especially, the physiatrist had a separate wheelchair clinic. That's all they basically dealt with were sort of the readaptations of things that needed to occur. And so we really tried to encourage them that in their wheelchair clinic, at least during that time, look at their butts and look at their heels. To see if there's any breakdown or early stage 1 pressure ulcers. There's a basic principle in pediatric: children grow, right? Well, at least we hope they do. Whereas adults tend to be more theoretically stagnant in the context that, hopefully our weight doesn't change unless you're like me and I just keep getting bigger and bigger. But children grow, and so you have to change various devices as the children grow in both weight and in length. You really have to work with your rehab docs in order to address that. And I'm a big, and I said this morning, I think that all wheelchair pressure ulcers are preventable. But the problem is that most children in a wheelchair do not have access to pressure mapping. And I'll just give you an example. This is sort of the irony. So Children's Hospital in Aurora, they have a wonderful physiatry program. It's probably the best in the nation. And they have a gait program. And they have a very specific a lab where they can do the gait analysis. It has the same number of cameras that Sony has in their lab when they develop video games. And we have this incredibly sophisticated system to do pressure mapping, and the physiatrists don't do any of it. And they refuse to do it. And so I went to actually the PhD guy who runs the gait lab, and we worked together, and we were finally able to get a lot of these kids pressure mapped. So I think it's very, very important to pressure map these kids on a regular basis, especially if there's been any rapid weight gain, any rapid weight loss, and this is true for your adult patients as well. And the one I think that we tend to forget is if there's been any major musculoskeletal surgery where their anatomy has changed, they need to have pressure mapping. Because one of the biggest things about doing flaps that the plastic surgeons don't like is because there's a relatively large failure rate. And I think one of the reasons for that is we do these large procedures on these children and on these adults, and then we throw them back in their same chair. And they really need to be re-pressure mapped anytime there is rapid weight gain or rapid weight loss or any large musculoskeletal surgery. I can't emphasize that enough, because that's typically where we would see the kids in our clinic come to us being referred as an outpatient clinic because one of those three things happened about 6 months ago, and they went back in their same exact chair. I'm not saying you need a new chair, you just need to be remapped and then have maybe a new seating device or something put in. The treatment of pressure ulcers is no different in children than it is in adults, except in the sense that you have to offload pressure, right? That's the common cause. So if you have to offload the pressure. And as you all know, I am, since Gary's still alive, I am a disciple of Gary Sibbald. So, you always just fall back on your time-dime paradigm with regards to your dressings and things like that. Because as you all know in this room, if you don't offload the pressure, you can put the most expensive dressings on you want. It's not going to heal. And so number one is offload the pressure first. And I think that, I can't emphasize enough, and again, preaching to the choir over here, frequent follow-up in the wound clinic and education on the parent side, but I would say more importantly, education on the physician side or the healthcare provider side, such as nurse practitioner or PA, with regards to what to look for down the road, either through primary care or physiatry or neurosurgery or any of those other healthcare people that interact with your patient. Education is very important so that they know what to look for. All right, so we talked, surgical wounds was the next one we talked about. And remember, we talked about that most of the surgical wounds that we see are wound dehiscence, and they're usually abdominal wound dehiscence, and gastroschisis is a very common one where the intestines and the stomach are on the outside when the baby is born, and then the surgeon has to wait for the baby to grow up and then put them back abdominally. And the space is usually pretty small and the surgery is pretty tight, and so wound dehiscence is not uncommon in this particular setting. And many times the surgeons will put a mesh to kind of help create a fake abdominal wall, if you will, and then we try to get tissue to grow over that. And wound vacs are used a lot in this particular setting, and for the most part, they actually work pretty well. Negative pressure therapy actually does work pretty well. And we've actually, in our institution, we published a case in literature where we had the surgeons, no matter what they tried, and the poor little boo went through multiple surgeries to try to get the abdominal wound closed, no matter what it would dehiss, and the mesh would just be there. Number one, you have to make sure that infection is under control and bioburden is down. And I think in retrospect, that's probably the biggest mistake that the surgeons, the pediatric surgeons, weren't really aware of biofilm and bioburden when it came to chronic wounds, because by now these are almost all chronic wounds. They're not acute wounds. And Surgeons, as a general rule, I'm not picking on them, they do wonderful work, but they're used to dealing with acute wounds, right? Because that's what they make. They make acute wounds, and pretty much all acute wounds heal, right? Because if acute wound doesn't heal, it becomes a chronic wound. And so really getting the bioburden and the infection under control first, and then what we've really had success with is actually using fibroblast living biological dressings and laying them down directly on the mesh, and then we typically would put Mepitel or some sort of silicon-based dressing over that, and then we'd actually, Dr. Fish earlier this morning talked about silver-based dressings, and then we put a silver-based dressing over there, and then we actually put the wound vac on. And actually that combination we have found actually works really, really well. In the paper we published, we had a little boo who'd had this open wound for about 3 months, and we got it closed, I think, in about 3 weeks by doing that. So it actually works. We found, and we've had subsequent cases where we've done this too. But the key to any biological dressing, whether you're using them in children or whether you're using them in adults, the key to any biological dressing is that you get bioburden under control. If there's high bioburden, you absolutely do not want to put it on any infected wound because the bacteria just eat up the living cells. And also those are acidic environments where you have lots of bacteria replicating. And so the key to any biologic living dressing, if you use them in your wound center, is, again, to get infection and bioburden under control. And then actually those work really, really well. I think that when folks have failures with biological dressings, it's because they're not addressing the bioburden as well as they should. And then basically this is just what I talked about. So we talked a little bit about epidermolysis bullosa, and I can't emphasize this enough that the people are always asking me, well, what are the top treatments for EB? And there are 5: nutrition, 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 and nutrition. And the children that take up your most time when it's epidermolysis bullosa tend to be the children that have recessive dystrophic EB because, number one, they live, and number two, they have the largest surface area with regards to their skin involved. And so you can see with this child here who has recessive dystrophic EB that the vast majority of nutrients that come into this child are going to go to wound healing if you just give them their regular calories. They're not going to go to growth, right? And so nutrition becomes paramount in taking care of these children. Now, there are several philosophies on how to deal with these children. Some countries just consider it's a genetic disease. We're not going to intervene very much, and whatever God wants to do, that's what happens. In the United States, what we do, and again, I don't know that there's a right answer, quite frankly, but what we do is we monitor their growth curve very closely. And as soon as their growth curve starts to plateau or starts to go down, we actually will put in a G-tube. And then we will start G-tube feedings in addition to trying to treat them or have them eat orally. But you have to remember in recessive dystrophic EB, and early on in some of the simplex, especially if you have generalized simplex disease, most of those children have intraoral disease, and so eating is quite painful. And in recessive dystrophic EB, they quite often have blisters on their lips and on their tongue and in their mouth. And so eating is very difficult. And most of these kids, as they get older, they have food avoidance because eating is so painful for them. But we try to keep them as much as normal children as possible, if we can, to include breastfeeding and things like that. But most of the time, because they have intraoral disease, eating becomes very difficult. So we'll put in a gastric tube and give them more calories, particularly at night when they feed. Now, the problem with all of this is that there's good data to show that EB is not just a skin disease, but collagen 7 is also very important in your gastrointestinal tract. And what happens within the lamina propria, which is one of the layers between the mucosa and the circulation, is in EB, that lamina propria gets thicker and thicker and thicker and thicker and thicker as the kid gets older and older and older. So there's a diffusion issue, and so there's a malabsorptive issue. And so even though you're giving them calories, they're not getting the calories that they need because of this malabsorptive issue. In addition to that, as they get older with these nighttime feeds, they also have typically chronic diarrhea because they're not absorbing as much formula as they should, and so then you get perianal breakdown, and it just can turn into a mess. And so that's why there are some countries who say, this is a genetic disease, we're not going to be able to fix it, and we'll sort of let God take care of it. So nutrition is the most important thing in epidermolysis bullosa. So the key, there was the engineering skin thing this morning. I was like, oh my God, let's just do this across the kid's EP back. I mean, that'd be fabulous. But you obviously need to use non-adherent dressings. You guys are fortunate. You guys have some humidity. We don't have any in Colorado. Vaseline gauze dries out in about 2 hours in Colorado. And so we add Vaseline to everything, including Vaseline. So the first thing that goes on Vaseline gauze is more Vaseline. And so we actually butter the silicone-based dressings or the non-adherent dressings, regardless of the type of non-adherent dressing. We actually Vaseline the crap out of it because everything dries out in Colorado. And that's your primary dressing. And then we will typically, if there's lots of exudate, we do use a lot of silver dressings in epidermolysis bullosa, and then we usually have some sort of foam dressing, as the tertiary dressing, especially if there's exudate or if there's some drainage for these. The reason I put on there recommend or consider long-term antibiotic therapy is because of the malabsorptive issue. It's not because these kids require, it's just you can't get serum levels high enough because they're not absorbing the antibiotic as well. So many times we'll have kids on antibiotics for about 3 months just so that we can get the antibiotic level high enough so that we can get infection under control. We try to do a lot of topical stuff, and I'll explain what that is. Dr. Fish talked about using Neosporin and Polysporin, and as a pediatric dermatologist, I about had a seizure in the third row. We hate Neosporin and Polysporin as pediatric dermatologists because it's very common to develop an allergy to. But what I liked very much about his talk was he used it once, and then they switched to silver dressings. They didn't use it over and over and over and over again. So we as pediatric dermatologists try to stay away from the antibiotics, topical antibiotics as much as possible. But with that being said, we do use them in EB at times to see if we can get superficial infection under control. And then we use a lot of biological dressings in our program trying to get areas to heal. One of the things that actually has changed our kids' lives is pool salt. So if you can imagine having no skin and you're trying to get into a tub, that's horribly, horribly, horribly painful. And so we learned this from our New Zealand colleagues that they put in pool salt. So it's 2 cups of pool salt. In the United States, we do put 2 cups of pool salt in a tub of water. And I remember we were having an EB meeting amongst our group. We have a multidisciplinary clinic. And the discussion was, well, how big is a New Zealand tub? And is it the same number of cups of salt? And I'm like, I don't know. So actually what we learn anecdotally is just by getting these kids in water, because basically 2 cups of pool salt in a tub of water makes the water isotonic, so that when they get in, it doesn't sting and burn. And so we've found that now we can't get our EB kids out of the bathtub because they love it so much. And you can add bleach as well to help with decreasing the staph population or the bacteria. And you can add that with the pool salt at the same time. And so we've learned that, and we actually published this data. It's in the literature. It's in the Peds Derm literature. One of my medical students, Brian Peterson, who's now a Mohs surgeon, he's the one who did this study, but we actually showed a decreased infection rate in our kids just by adding the pool salt, not even adding bleach, just by adding the pool salt and getting the kids in underwater. I'm running out of time, so now we're going to turn this into a thing. Okay, so I think this is actually my last slide. Yeah. So we talked. The last one we talked about was ulcerated hemangiomas. As I said, one of the reasons I'm a pediatric dermatologist is there's not a lot of pediatric dermatology emergencies, so I get to sleep throughout the night. But this is a pediatric dermatology emergency, an ulcerated hemangioma, and the main reason for that is because of the pain associated with these. You need to get these healed, and the way we do that is we bring them into clinic and we use a pulsed dye laser. Either the 595 or the 585. In my clinic, we have the 595. And as Dr. Fish talked about earlier with the pulse dye laser, basically what it does is it blows up blood vessels. And basically it takes a chronic wound and turns it into an acute wound is one of the main things it does with the hemangioma. And then we also use, again, non-adherent dressings. I think at least in ulcerated hemangiomas, the silicone dressings work the best. And for reasons that I don't quite understand, these ulcerated hemangiomas become mixed colonized very, very quickly. So most of the time when you look at a wound, it's gram-positives, and then after a couple of weeks, it's probably a little bit of anaerobes, and then after maybe a week or so, then you have to talk about gram-negative. For reasons that, again, they're not clear to me, ulcerated hemangiomas have mixed colonization quite quickly. And so one of the things that I do is I start right away with metronidazole. And just add it directly to the wound bed. So I add metronidazole first, or I'll butter the non-adherent dressing with the metronidazole, and then put it down, and then secure that after we do the laser. And I probably do the laser a couple of times a week, probably twice a week. Bring them back and laser it again. This is becoming rarer and rarer because we now use propranolol earlier now. And so we're not running into the issues as much anymore with ulcerated hemangiomas because those that are high risk for ulcerations are being treated faster with propranolol, which just shrinks these down to nothing. Thank you.
Do you have any questions?
Alan, what do you think about the stem cell work, the trial on EB?
The stem cell work. Okay. So I think that the data that so these are kids that you're talking about the bone marrow transplant? Yeah. So these are kids with recessive dystrophic EB. In fact, our center does that. These are kids with recessive dystrophic EB who get a bone marrow transplant. And essentially, this was originally done out of Wisconsin. Yeah, Wisconsin. And John McGrath, who's actually in the UK, was the blind, who I know. And John and I were at a meeting. He was the blind reader of the results of the original kids who got a bone marrow transplant. And he basically felt like the electron microscopy studies and some of the data that he saw, and I feel the same exact way. We basically, with bone marrow transplant, have taken a recessive dystrophic EB patient and we've made them a dominant dystrophic EB patient. They just blister a little bit less. They don't have as much intraoral lesion. The kids that live, their quality of life is slightly better. I praise people for doing it. It's not the answer, but I think it's going to be part of getting us to the answer with this. So at the end of the day, bone marrow transplant is certainly not curative for recessive dystrophic EB, at least. Yes, ma'am.
I'm sorry, I came in late. You probably answered this question already. How much bleach do you have in water?
How much bleach?
So that's an exciting question.
It depends. Some people just say a capful of water, and other people say, 2 capfuls of water. Some people say a quarter of a cup. I just usually recommend a cup or two, a cap or two of bleach. Yeah, you don't need very much. You don't need very much at all. But again, our study showed that just getting them in the water with the pool salt dramatically decreased their colonization and the issues that we had with infection. And the other interesting thing is we decreased their narcotic use by 80%. With regards to pain control, which is huge for these kids. And the other thing that's huge for these kids is pruritus. And we decrease their antihistamine rate as well, the antihistamine use, because the pruritus in EB is not well controlled with your typical cetirizine, hydroxyzine, doxepin sort of thing. They still have horrible, horrible, horrible pruritus. The adults do too. And so the salt baths have actually helped with that as well, which has really changed the quality of life for these kids. So it's interesting that of all the things that we did at our center and all the things that we do at our center, the thing that makes the most impact is add a bunch of salt to the water. So, it's always go back to the simple stuff. The most expensive stuff a lot of times doesn't work. So,
Talking about the simple stuff, what do you think about honey dressings?
honey dressings. So I like honey dressings. The thing that I like honey dressings and wound care in general, I think they actually are very good autolytic debriders. The FDA in the United States does not let us say the word antimicrobial when it comes to honey dressings, but I do think there is an antimicrobial role. We use them in EB. I use them a lot in wound care. In fact, I have a kid right now. My biggest challenge right now in my wound clinic is a kid with this vascular shunting genetic abnormality called cutis marmorata telangiectasis congenita. And these kids are often born with ulcers. And she has two large ulcers on her scalp that we're now treating with MetaHoney because we did them on the knees, and the knees are almost healed. The biggest issue in EB is it stings and burns a lot. So in EB kids, I haven't really found MetaHoney to be that useful over large areas. But if you've got like a spot or two that you're trying to get under control, and they're older children, and you can kind of walk them through the stinging and burning, I think MetaHoney is a good choice. But to do something like on the entire back or something like that, the kids tend not to tolerate it very well. Oh, and just the other thing, these are tips in pediatric wounds. When it comes to EB, one of the things that I have that I talk to my families about is it's very, very important for these children to develop developmental milestones. And this is true regardless of whether you're talking about EB, an abdominal wound, burns, or anything. It's so important that these kids try to have a normal life and develop their developmental milestones. And so what I tell parents is, we've got to get your kid to start crawling and start walking. And the first thing that comes out of their mouth is they're going to blister or it's going to be painful. And I say, I know, but we're going to get through it because it's important that they learn how to crawl and they learn how to walk. And so our team really, really works a lot with the families to really help these children meet their developmental milestones. That's key. And the other thing is have good pediatric wound nurses where you can develop I can't tell you the number of times we've had kids referred into us, and the dressing that is on the kid is restrictive, and they're bound down, and we're like, "How's the kid move?" And the parents are like, "They don't." And so, really becoming and the best people to talk to are the parents, because the parents know how to do dressings much better, I think, sometimes than we do. And and I give the parents lots of leeway and say, look, if the dressing we're putting on today doesn't count or doesn't work for your child, this is really all I care about. I want this to be the primary dressing, and I want this to be the secondary dressing. After that, you figure out how it's going to work for your child. And parents are quite ingenious, and we've learned a lot from our parents about how to do particular dressings on children so that they have the mobility and they can meet those developmental milestones. Yes, ma'am.
I hear a lot about autolytic debriders, especially for the pediatric population. Can you explain, I understand how enzymatic debriders work in cannabis surgical, but can you explain how autolytic debriders work?
So autolytic debridement is basically you're just using the patient's own tissue and enzymes within the own tissue to kind of break down and get rid of all that dead skin. So that's basically the difference between, so enzymatic debridement uses enzymes that are in the product that you're using to break down the tissue. Here, you're just using the body's own tissue, and it's a balance. This is one of the things that Gary has worked Gary Sibbald and his group of work, and Pat Coates is in the audience. Thank you, Pat, for being here. That's where the moisture balance comes in, all right? So that's really where I think autolytic debridement and moisture balance play a role. So you don't want too much fluid in your wound because you're just going to get wound maceration. You don't want it to dry out because then you're going to get an eschar and inhibit keratinocyte migration. And as Dr. Fish talked about this morning, dead tissue and eschar is just a petri dish for bacteria. So if you want a wound to get infected, get an eschar and get dead skin in there. So autolytic debridement in my world is really that balance between using the patient's own natural wound fluid and your dressings so that you have the right moisture balance so that you can get that debridement of the dead tissue.
So if a company claims to promote autolytic debridement, what they're basically saying is they're promoting a moist wound environment.
That's what I would think. Yeah. There's not a particular thing that you add for autolytic debridement per se. It's the moisture balance. If you're adding anything, it's a hydrogel or something for moisture balance, so you can get that autolytic debridement. Yeah. Yes, Pat. Oh, I'm not going to be able to answer a question that you're going to ask.
Sorry, you're the last one.
I wasn't here this morning, sorry.
Oh.
Can you say more than one word about adhesives in EB?
Oh.
Oh.
I think the next session is about this.
Is the next session on that?
I think so.
Okay.
Yes, it is about. And
Yeah.
after that, if you don't get your answer,
Yeah, then I'll answer.
you come back.
Yeah. All right. Thank you.
Thank you so much.